For millions of people around the world, the idea of traveling for healthcare is, well, it's incredibly compelling, isn't it?
It is.
You're looking to get past huge waiting lists, find a price you can actually afford for a procedure that could change your life, or, just get a quality of care you can't find at home.
And the marketing is very slick. It's presented as this glossy, sophisticated, seamless route to better health.
But as I think many of us working in medicine know, that journey is so often shadowed by these profound, really complex risks that go way beyond just the operating theater.
That's right.
These aren't just isolated incidents. They create hidden costs and vulnerabilities, not just for the patient's health system back home, but also for the host communities they visit.
Exactly.
So today we're doing a deep dive into the ethical, legal, and social maze of medical tourism. We want to move past the simple cost-benefit analysis and really get to the true systemic costs. And I'm delighted to be joined by our expert guests. Welcome.
Thank you. It's a vital discussion, especially for the clinicians and health administrators listening. I mean, you are the people who most often end up managing the, frankly, very complex aftermath of these decisions.
That's a great point.
We really need to stop framing this as tourism and start seeing it for what it is, a fragmented, unregulated form of transnational healthcare.
Okay, so let's unpack that. Let's start where, as you say, the rubber meets the road for a practicing clinician.
Yeah.
The very unique clinical risks for the traveling patient.
Mm-hmm.
We all know risk is part of medicine, but this seems to amplify it, doesn't it? Minimal pre-op consultations, relying on a slick website for quality control.
That's absolutely right. And while, the catastrophic outcomes, a death on the table, a major surgical failure, are the things that make headlines.
The most visible tragedies.
Exactly. The wider public health threat is actually what should be driving policy, and that is the acquisition and then the importation of multi-drug resistant bacteria, the superbugs.
Right, so a personal choice becomes a public health crisis.
It's a textbook negative externality. Think about it. A patient travels for a relatively cheap cosmetic procedure, and they come home colonized with a dangerous pathogen, something like a carbapenemase-producing organism.
Something their home country might have very little exposure to.
Precisely. We've seen documented reports of this among U.S. patients after procedures in Mexico, for instance. And in that moment, a personal medical choice shifts the entire public health cost. The screening, the isolation, the incredibly expensive treatment onto the publicly funded health system back home.
And I can only imagine for the clinician back here, dealing with the fallout is incredibly difficult, especially with what's often called the aftercare gap. What does that look like when that patient walks into A&E?
Well, the implications can be, quite dire. We have good evidence showing that medical tourists frequently return with terrible documentation.
Or none at all.
Or none at all. The records are incomplete, they're often untranslated, or they just plain don't exist. And this makes any kind of safe, structured follow-up care virtually impossible.
So the home team is flying blind.
Completely. The primary care doctor, or the surgical team back home, is left in an impossible position, both ethically and professionally. They're trying to manage complications, say, a deep surgical site infection, from a procedure they know nothing about, performed by a doctor they've never heard of.
With no records.
No records of what was done, what implants were used, what the post-op plan was. It creates this profound and really dangerous knowledge gap, and it places the entire burden of investigation and liability squarely on the home provider.
And when things do go wrong clinically, as they sometimes do, the legal safety net just seems to evaporate. Is that right? If a patient has signed a waiver, is there any real recourse, or is it a legal black hole?
For all intents and purposes, it is a legal black hole. The very idea of medical malpractice liability is often just an illusion for the medical tourist.
Why is that?
The logistical barriers are just designed to be overwhelming. The travel costs, translating documents, trying to navigate a foreign legal system, finding local representation. It's all designed to make you give up.
Of course.
And crucially, that near total lack of legal exposure removes a really powerful incentive for quality improvement over there. If a provider faces no real litigation risk, where's the economic pressure to invest in top-tier international SASE protocols?
Which puts the home medical team in such a difficult position, caught between their duty of care and this completely unknown risk.
And this journey isn't usually taken alone, is it? There's often a facilitator involved. How does that add another layer of risk?
This is where the whole concept of informed consent just gets completely undermined.
How so?
The patient puts enormous trust in this facilitator. They see them as an impartial guide, helping them find the safest, best hospital. but the entire business model is almost always based on an unregulated conflict of interest.
You mean referral fees?
Exactly. We know these facilitators are often paid, sometimes thousands of dollars per patient, by the foreign hospitals they send people to. And this fee is almost never disclosed to the patient.
So the facilitator's motivation isn't the patient's best clinical option. It's the highest referral fee. That lack of transparency just fundamentally compromises the principle of informed consent. The patient thinks they're making a free choice, but they're choosing based on a flawed, financially motivated recommendation.
So we've covered the patient's individual risks and the immense strain on the medical team back home picking up the pieces. Let's pivot now and look at the cost to the destination country, the host's dilemma. You say the internal brain drain is the central ethical problem here.
It's a critical issue of justice and equity, really. Internal brain drain is what happens when highly skilled local doctors, nurses, and technicians are siphoned away from the public sector
Where they're serving their own population.
and into these private, often foreign-owned hospitals that cater exclusively to medical tourists. The reason is purely economic. The salary differences can be colossal.
I can imagine.
A private facility can offer wages the public health budget just can't compete with. This drains vital talent from the national health system, and it creates a deeply unfair two-tier structure.
And the injustice is that the state often paid for their training in the first place.
That's the real sting in the tail. The state-funded medical education system has effectively subsidized the training of these professionals, only for their skills to be immediately commercialized for the benefit of foreign customers.
But if the business model works, if it brings in revenue, is that brain drain just an unavoidable consequence of market forces? How do we stop it being a zero-sum game where the local population always loses out?
That's the crucial question. And the evidence suggests it's not inevitable at all. It's a failure of policy and corporate responsibility. We have models that prove it can be done differently.
Okay, such as?
Take Narayana Health in India. They have what they call a lean, green, and social model. They focus on high-volume, cost-efficient operations. They even run their campus mostly on solar power to save money. And here's the key.
Yeah.
Those savings are reinvested. They run a tiered pricing system. The income they generate from international full-paying patients acts as a direct subsidy. It allows them to provide drastically reduced or even free care for the local poor through community health camps.
So the international patient revenue is actually funding a public good.
It transforms a private service into a public good, yes.
That's fascinating. So you're turning brain drain into what you call brain share.
Well, for that, the Bali model is an excellent example of just appropriate regulation.
What do they do?
To get a license to practice medicine on tourists in Bali, doctors have to agree to donate an equivalent, mandated amount of their time to the local Balinese public health system.
Oh, that's clever.
It is. The policy forces the private sector to share the human capital that it depends on. It ensures those high-demand skills benefit both sides.
And it's not just about the doctors and nurses. The host community also ends up carrying these broader social and environmental burdens.
Precisely. And that really highlights the final layer of this distributive injustice. The private operators get the economic benefit, but the societal costs, especially environmental ones, are socialized, pushed onto the local community.
What kind of costs?
Well, the documented example of 100 tons of garbage being collected daily from beaches in places like Bali says it all. The local community is left to manage the environmental degradation and strained infrastructure, while the private medical facilities just profit.
Okay, if we shift our focus back home again, the patient's country is facing this massive policy gap. How much should the state really step in to protect its citizens from all these risks?
It's a fundamental philosophical conflict, and it leads to paralysis. On one side, you have the libertarian view,
Which is?
that the state's job ends with providing information. It should respect an individual's freedom to fail. The only time to intervene is to prevent those dangerous externalities we talked about, like the superbugs.
And the other side.
The paternalist view. This argues the state has a duty to protect individuals from bad choices, especially because of the huge information imbalance in complex medical decisions. The patient just can't be an expert.
And governments caught between those two powerful ideas, they just do nothing.
They default to inaction. It's often called the trilemma of regulatory intervention. Any policy you propose immediately gets stuck between three conflicting demands.
Which are?
It has to be efficient, cheap, and easy to run. It has to avoid over-inclusivity, so you're not banning legitimate, safe care abroad. And it has to satisfy the scope of justified paternalism. knowing how far is too far.
And because you can't satisfy all three at once.
The policy defaults to the path of least resistance.
Yeah.
Just provide information and let the patient decide.
But the second a government does that, it puts the entire weight of risk assessment on the patient. And that feels impossible when safety is being deliberately confused with hospitality. What does the accreditation landscape actually look like for them?
This is the critical flaw in that information-only policy. The common approach is channeling by accreditation, where you outsource quality control. And the gold standard for clinical quality, the one comparable to a major hospital here in the UK or in the US, is the Joint Commission International, or JCI.
So JCI is what you should look for.
Yes, it verifies rigorous standards, patient safety, infection control, medication management, real clinical stuff.
That sounds simple enough. So where does the confusion come in?
The confusion is created by a really devastating halo effect. This is where high-stakes medical accreditation gets muddled up with low-stakes hospitality labels, and they're all presented on a website with the same visual authority of a safety seal.
So the patient sees a bunch of impressive-looking logos.
Exactly. They see a logo for, say, ISO 22000 and think quality, but that's a standard for food safety management. Or they see Mexico's Distintivo H, which is about food hygiene in restaurants.
Not exactly relevant to a hip replacement?
Not at all. Or they'll see a Safe Hotels certification, which is only about security and fire safety. Or even a GHA Well Hotel Award, which is about the wellness and hospitality experience, the nice spa, the comfortable rooms, not the surgery itself.
So the patient is looking at 4 or 5 different logos, and only one of them, maybe, has anything to do with the actual clinical procedure they're about to have.
Precisely. And that signal confusion makes an information-only policy deeply, deeply flawed. It asks a patient who is already stressed and unwell to become an expert decoder of international certification standards just to stay safe. They simply can't tell the difference between clinical rigor and good catering.
It's clear these gaps are systemic. They require transnational solutions. So what frameworks are starting to emerge to shift us away from this fragmented tourism model and towards something more like integrated transnational healthcare?
The biggest driver for change is always economic, systemic portability. When public payers like governments or national insurers get involved, they demand regulation. The best example is the EU Directive 2011-24 EU. It didn't ban cross-border care. It formalized and regulated it. It clarified citizens' rights. It set up reimbursement systems. It's no longer tourism. It's a portable public health system with standards.
Are we seeing that anywhere else?
There are early discussions in the U.S. about allowing Medicare to be used by retirees in countries like Mexico. If that happens, it would act as a massive channeling and regulatory force overnight.
And on the moral front, what's the blueprint for creating a set of shared global ethics in this space?
We actually already have one, and it was created in response to an even darker practice, the Declaration of Istanbul in 2008.
That was about organ trafficking.
It was. It established a global ethical consensus that defined and condemned organ trafficking and transplant tourism. And it worked because it was rooted in moral outrage at the exploitation of vulnerable people. That framework proves that a global consensus is achievable for high-risk medical travel.
And it could be adapted.
It absolutely could be adapted to address other high-risk areas, like the marketing of unproven stem cell therapies or dangerous cosmetic procedures.
This has been a really powerful look at how we move away from just calling this tourism and start treating it as a flawed but hopefully fixable global system. It seems that for you, the medical professional listening, building an ethically sound future needs 3 pillars. That systemic portability, like the EU model, shared global ethics based on things like the Declaration of Istanbul, and mandated social responsibility like we see with Narayana Health and the Bali regulations. If this discussion resonated with you in your practice, please take a moment to rate and share our deep dive.
And if I could, I'd like to leave you with one final thought. The systemic flaws we see today are inherent to a practice that is guided by the ethics and expectations of leisure and hospitality.
Which prioritizes customer satisfaction.
Customer satisfaction, aesthetics, the experience, not the fundamental principles of healthcare, which demand standardized clinical safety and equity. The real challenge for us in the medical community isn't just treating the complications that come home. It's advocating for the paradigm shift that turns this fragmented market into an integrated, equitable, global health system.
An essential point to end on. Thank you so much for synthesizing all this complex information for us today and for giving us a clear framework for action.
My pleasure.
And thank you for listening. Join us next time for another deep dive.